Welcome and thank you, Oncology Club, Dr. Mustafa, Dr. Kamal, for inviting me. This is my first time in Bangladesh. I am going to talk, inshallah, about de-escalation radiotherapy for HPV-positive head and neck cancer. Also, thank you, Dr. Shabna, for making my life easier. So this is the agenda. Go through an introduction about HPV and the mediated radiation sensitivity, why de-escalation and strategies, and some learning points. So as you know that HPV is mainly a DNA oncovirus, and there are about 120 different types. Low-risk type like 6 and 11, they cause benign proliferation of the epithelium, and high-risk oncogenic types like 16 and 18, mainly causing the cervical cancer, vaginal or anogenital cancers. So how it works, it mainly starts with the infection with the HPV, followed by genomic integration of the virus with the DNA. This will lead to E6 and E7 expression, and these E6 and E7 will inhibit or inactivate B53, the tumor suppressor gene, and this will lead to the transformation and proliferation of the malignancy. And remember that E6 and E7 oncoproteins causes immortalization of the cells, which lead to malignant transformation and population. So there are different types of HPV testing, and these different types were used in different trials. So maybe the studies they are not the same. So it's mainly by the immunohistochemistry, PCR, and in situ hybridization. We have to remember that HPV virus or HPV-induced tumors, they have different entity. So different staging system, as you can see here, per the NCC guidelines. So there is different T and N categories for the overall stage grouping. For example, in the B16 negative, stage 1 includes only T1 and 0. But with the P16 positive, stage 1 includes T1, T2, and even in one disease. So also there is grading and differentiation of the P16 positive cancer. Often they are poorly differentiated. But this poor differentiation does not carry the same negative prognosis weight as it does with the P16 negative. And you can see here with the HPV positive oropharyngeal. So why we are saying oropharyngeal cancer? Because HPV positive is mostly causing oropharyngeal cancer rather than other parts of the head and neck tumors. So with the stage 1, the overall survival is very high. It's like 95%, with stage 2 up to 85%, and so on. However, there are additional prognostic factors that may affect the survival. For example, smoking history more than 10 pack here can reduce the overall survival for those patients who have HPV positive oropharyngeal cancer. Age less than 60, for example, improve the survival, and so on. So as I said, the HPV positive oropharyngeal squamous cell carcinoma, they have different epidemiology, clinical, anatomical, radiological behavior, and also prognostic characteristics from those with the HPV negative cancers. Now we have to remember that TUBA-correlated oropharyngeal cancer, they are characterized by P53 mutation and downregulation of B16. This is the opposite with the HPV positive tumors. They have the P53 they have inverse correlation between the presence of the HPV and the P53 mutations. Remember, it always present, not always, but like mostly present with small t and big N. For example, it can present with like 2 centimeter tumor and N3 disease. And usually the N stage is cystic and multi-level. So the histology, as I said, it is usually it's poorly differentiation. And the incidence of distant metastasis with HPV positive is lower than the P16 negative tumors. Quick, because of for sake of time, usually the presentation or the characteristic of HPV positive tumors is usually it appears with the non-smoker, male, younger, Caucasian, multiple partners, and higher education. Its appearance usually in the tonsil and base of tongue, and it presents with painless neck mass. Lots of studies have studied the difference between the P16 positive and negative, and they found that there is better overall survival and disease-free survival with P16 positive disease. As you can see, one of the famous studies is the Fakari in 2008. And the estimated risk of death for HPV-positive oropharyngeal squamous cell carcinoma is 50% lower than those who have a negative disease. This is a nomogram done by Fakari, and it collects points to predict the overall survival and disease-free survival for patients with P16 positive oropharyngeal squamous cell carcinoma. So why does the HPV-positive oropharyngeal carcinoma have better prognosis? Maybe because they have fewer genetic alteration, and this will enhance the therapy response, greater radiosensitivity, and we will go through this shortly. There is no field cancerization, so there is reduced risk of recurrence. Strong immune response because the virus enhance the immunity and immunology. And usually patients with the P16 positive tumors, they are younger, fitter, and they contribute to the better overall survival. So HPV-mediated radiation sensitivity, why these tumors, they are sensitive to radiation, and we may consider lowering the dose. It's maybe because the virus disrupt the DNA repair of the cancer cell, so the cancer cell cannot repair itself. Also, the virus arrests the cell cycle at G2M phase, so it's easier for radiation to work. Also, they reduce hypoxia. And also, we know that if there is a virus, the immune system is activated, so radiation can work in a better environment. Now, the de-escalation, what is the aim of de-escalation? We want to improve the therapeutic ratio by maintaining high cure rates, but we want to reduce the toxicity. Remember, those patients, usually they are younger and fitter patients, and they may live longer. So we want to avoid long-term side effects for these patients. So the de-escalation is strategies is reducing not only the radiation dose, maybe also modifying the chemotherapy or using minimally invasive surgery. So the de-escalation strategies are either RT-centric, like reducing the total dose from 70 to 60 gray, or altering the fractionation, or surgery-centric by, for example, minimally invasive surgery like transoral surgery, and we can use adjuvant radiation if needed. Lots of studies have been done with for the HPV-positive tumors. I will go through them quickly. One of them is the RTOG 1016, is the phase 3 trial and inferiority. It's mainly radiation plus cetuximab versus radiation plus cisplatin. Of course, I'm talking about HPV, so I'll not repeat HPV each time. And the goal was to test if cetuximab could safely replace cisplatin as de-escalation. The outcome was no. Cetuximab was inferior to cisplatin. Another study mentioned by Dr. Shabna, also the de-escalate, and it was also again the cetuximab plus radiation versus RT and cisplatin in the low-risk patients, and again cetuximab had worse tumor control. And the NRG-NOO2 study, it was mainly for the good risk patients, 60 gray and 30 fraction with concurrent cisplatin versus 60 gray accelerated radiation alone without chemotherapy, and they found that the concurrent chemoradiation met the progression-free survival, and RT alone did not meet PFS threshold. The orator was also mentioned by Dr. Shabna, so I'll not go through it. And quickly, the take-home message is we have to be careful that AGCC did not mention the smoking history, but the RTOG 0129 found that less than 10 pack years was crucial for defining the best prognosis for lower risk group. cisplatin remains essential, so replacing it with cetuximab leads to worse survival, and the standard of care of 70 gray IMRT with cisplatin achieving outstanding progression-free survival unmatched by the de-escalation. Reducing radiation to 6 gray with concurrent chemotherapy was inferior, and the post-operative de-escalation to 50 gray is safe for select low-risk group patients, and de-escalation remain experimental. So we have to be careful choosing which patient should go for the de-escalation for radiation or for chemotherapy or systemic therapy, and none have a proven non-inferior outside the setting of clinical trials. With this, I conclude my presentation. Thank you very much.
Thank you, Dr. Thuraya Al-Hajri.